Hi, good morning, everyone. Since there were some technical difficulties and we're running a little late, we'll get started. So I'll just share my screen. Uh, Hold on. There we are. Can you see the my screen? Don't have confirmation, but I'll start the ball rolling. I think we have enough people to so we can start, and then hopefully the other people or attendants can join in on us. Okay. Thank you for confirmation. Okay. So good morning. Pardon the delays. I'm Dr. Julian Ferrer of the Department of Orthopedics of Quirino Memorial Medical Center, and this is EHQUIP Series 4, lecture on fragility fractures. Okay. All right, let's get started. Little bit of a summary of what we're gonna discuss. I'll tailor fit it to our timeline. I hope to be done by 12, so I might cut out some content from my original plan for this lecture. So, if you haven't heard of the concept yet, fragility fractures pertain to these factors: osteoporosis, sarcopenia, which may be a concept that even the usual lay people have not heard of. We are going to try to understand the pathophysiology and its long-term effects, understand the value of a multidisciplinary approach, which our hospital is actually able to give to our patients. And I'll mention some projects that we have running that try to promote or advocate this multidisciplinary team approach. And then, of course, treatment adherence and prevention and follow-up. Before I forget, thank you again for attending, whether or not you're part of the medical team, even admin, or maybe even your acquaintances or lay people or non-medical related people. This lecture will serve to at least give you an overview and an understanding of fragility fracture so we can raise awareness, which is one of our advocacies as part of the fragility fracture network in the Philippines. Okay, so if you have friends or family that want to attend, maybe you can still invite them. I see something in the chat. If you want to have any questions, please go right ahead. But I'll try to go breeze through quickly because of our time constraint. Okay. All right. As you can imagine, fragility fractures are fractures sustained with minimal trauma. Usually, those are in the hip, which is the most research, and I'll be delving more into it in this session. And the vertebrae or spine, the wrist or the part of the forearm are near the hand, the upper arm or our proximal humerus, and there are other parts of the skeletal body that do sustain fragility fractures, such as the ankle, although they are less researched as of now, but they can be considered part of this fragility fracture classification. Fragility fractures is a multifactorial disease. You basically subdivide it into two major factors, which is number one, fragility or decreased mineral bone density. Most of you probably understand it as osteoporosis or the biomechanical factor in fragility fractures. We'll go into it in a bit. And the second one is something that I really want you to take home from this lecture is frailty and sarcopenia, which is the physiologic factor. It deals with not with the muscles, not just it's not just the bones that are actually our problem during fragility fractures. All right, let's go first to the first major factor, which is fragility. It is decreased bone mineral density or the biomechanical factor. You may well know this as osteoporosis, and osteopenia is the severity just before it becomes full-blown osteoporosis. I highlighted here that it has no symptoms, which a lot of patients mistake for They think that if you have osteoporosis, you have to feel something, or sometimes they mix it up with osteoarthritis. And then there are multiple modifiable risk factors such as your age, your gender, ethnicity, family history, of course, a small body frame. So unfortunately, Filipinos or Asian people of descent are more prone to fragility fractures, and the Westerners have less of it. And of course, endocrine problems such as menopause. Modifiable risk factors are what we will be discussing thoroughly, probably in this lecture. Low calcium, so it's in the diet. Vitamin D, we'll go into that later. Low exposure to sunlight is related to vitamin D. Prolonged immobility, so couch potatoes in particular, and of course, our senior citizens who don't go out as often or are not as active are prone to fragility fractures. Having a low BMI. So, uh, even if you're large, a little on the heavy side, if your body mass index is not appropriate for your frame, it is also not a good. It does not necessarily mean that you're healthy. I'll go into that later, but I suppose it's more for the frailty side or sarcopenia. Low physical activity, like I mentioned before, smoking and alcohol. Other medications that can be contributory to fragility fractures are the following, of course, those that can affect our endocrine system, and of course our calcium and phosphate, the kidneys, and the like. Chemotherapy are also included, and like I mentioned, here we have yeah. Oh, sorry. You can see on the picture on the left, that's a normal bone. That's what it looks like, supposed to be on your X-ray and even on your bone densitometry. And the one on the right is osteoporosis. You can note that there are larger holes or trabeculae, making it more fragile. So, pathophysiology. There are two types of osteoporosis. In terms of pathophysiology, the primary is subdivided into postmenopausal. So women at 60 or when they have postmenopause already are prone to osteoporosis because their calcium, vitamin D, and other endocrine systems do not function as well as they did before their menopause. And then senile, which is basically just wear and tear or aging related. Secondary are those related to metabolic disease, for example, chronic kidney disease, sometimes rheumatoid arthritis, and the like can affect your bone deposition or your bone restructuring, and also drug-induced. Something of note, although we have recommended bone protection medications, there are certain algorithms for you to take. So it's not just about taking a bone medication preparation. You also have to ask your doctor, how long are you going to take it? How long before you recheck your bone densitometry? Should you stop or have what you call a vacation from the medication? Because some of these medications, when you suddenly stop or you do not change or shift, either plateaus or significantly goes down, which may maybe not necessarily aggravate your osteoporosis, but can lead you into a stage or a portion of time that your bone mineral density will actually go down. So it's still important to consult your doctor, more so if you've been on anti-osteoporotics or bone promoting drugs for a long period of time. Relevant pathologies, I won't go into all the nitty-gritty. That should be reserved for a separate lecture. But you have, again, endocrine problems, hematologic, GI, rheumatoid arthritis, of course, included, renal, which is very important for CKD patients, neurological, uh, genetic, and of course, the other possible contributing factors, which at the end you can see depression is part of it. So again, fragility fractures is not just one phase thing; it's multifactorial. You have to consider multiple items in the patient's profile. Okay. Pardon, I think the some of the pictures were not able to transfer during my preparation. So diagnosing osteoporosis, bone densitometry. Usually we do a BMD. Unfortunately, we don't have in our hospital. We send them out, and usually what you're looking for is a T-score. So if you note, I highlighted there a T-score of less than negative 2.5, either of the lumbar spine or the femoral neck, because your bone mineral densitometry actually scans you from head to toe. And there are certain areas of the skeletal system that are representative of how your bone density is, because um, depending on how the patient functions, some of their bones in the body might be a little more resilient or stronger than the other parts, such as, again, your lumbar spine, your femoral neck, which are, again, prone to fragility fractures. So, um, there are other modalities besides bone densitometry. You have the dual energy X-ray absorptiometry scan, which is basically BMD. Um, and then you have to know, some people might ask you, if, for example, a relative of yours asks for you to interpret their results, sometimes it shows a T score, sometimes the Z score. So the important thing we have to take note here is the T score. It's the BMD of the average young white female. So we have clinical practice guidelines published in 2023 for the Philippines, and we're because again the T-score was initially made for Westerners, we have some adjustments made in our CPG so that we can stratify it to the Filipino population or even to the Asian population. But I won't go into it. A majority of fragility fractures occur with patients at the level of osteopenia, which is T-score of -1 to -2.5. So you don't have to have a T-score of -2.5 to sustain a fragility fracture. So if certain conditions happen, even with minimal trauma, for example, your mother or your grandmother, your grandfather fall, even if in an osteopenic state, they might sustain a fragility fracture, which again we want to promote awareness of, because most of the time it's just a small trip going to the bathroom at night, and probably your mom, your dad, your grandparents slipped and fell on their buttocks, and then it's over. It's a fragility fracture already. Versus the Z-score, it's more for the doctors and for research, so I won't go into it. Having a fragility fracture, so for example, you're 60 years old, you slipped and fell, you sustained a hip fracture, that's automatically a sign that you are osteoporotic. Other modes of diagnosis, you have a quantitative CT. I don't know of a hospital right now who has this running. Probably major private institutions have this, although BMD more often than not is the more cost-efficient way of diagnosing osteopenia and osteoporosis. You also have a quantitative ultrasound. I haven't encountered one in the institutions that I work with in terms of this, but again, this is more for research purposes. Laboratory tests, of course, you have the standards, and again, I won't go into detail, but suffice to say, there are certain laboratory tests that you want to confirm whether or not, like I mentioned earlier, it's a primary or a secondary type of osteoporosis, because it can be related to your endocrine or your kidney. So, your doctor will probably ask for certain lab tests to confirm whether it's related to your aging, maybe it's metabolic related, and that alarm actually says it's 11 o'clock. So I'll try to hasten it a bit. Okay, quick Q&A. You can just enter in the chat box. You have a patient, asks for you to interpret her BMD. She has a T-score of -2.6. How would you interpret this finding? Anybody? Unfortunately, we are doing this via Zoom, so I don't have a gift for you or a prize if you give the correct answer. He scored -2.6. Again, it's not positive, but it's negative. Anybody? Okay. Yeah, Zoom is a little more difficult in terms of engaging the audience. So in the interest of time, I'll answer myself. It's actually osteoporosis because it's negative 2.6. It's beyond negative 2.5, which is the start of osteoporosis. All right, a little more into it. Here you have a diagram on the right. Simple exercises. If you want to take a picture of it, you can recommend this to your parents or your grandparents so that they can start some weight-bearing exercises to help out with osteoporosis. Because there is a concept in orthopedics or basic physiology and basic science that if you use your body, your brain will send the respective neurotransmitters or modulators to that part of the body to help with dealing with the stress. So if you regularly go on walks, it will recognize, your body will recognize, your brain will recognize that you're actually moving around. So it will send support to your bones to be able to sustain your lifestyle of walking. So it is a World Health Organization recommendation to do walking. It's quite safe even for arthritis, and it will at least maintain some level of density in your bones for your lower extremities, for your hip, your femur, your knees, your legs, etc. Okay. Like I mentioned earlier, a fragility fracture itself is already tantamount to osteoporosis. You would warrant initiation of anti-resorptive medication even without that BMD. And actually, more often than not, 60 years old, it is recommended to start on anti-resorptive medication. In some countries, unfortunately, they tag um, people aged 55 or even as low as 50 as a little old already. So, unfortunately, I can call you senior already if you're around 50 years old. I'm not putting you down, but it's just a way for basically research and our body to say that at the age of 50 and above, your body's not as strong as you were before. So, you will need support to protect yourself from these pathologies like osteoporosis. So the concerns with oral medications are the usual side effects of esophagitis or gastric irritation. So we have to be wary of that. Um, and then hormone replacement treatment is reserved usually for postmenopausal women who have ongoing medications with their, for example, their ovaries or their uterus. They might opt a different set of drugs compared to the one that your orthopedic or your rheumatologist might prescribe for you. So it's again a multidisciplinary thing. You have to consult multiple doctors or at least get guided into what medication is appropriate for you. Oh, before I forget, although there is menopause for women, men also have what you call andropause at about age 70, and their bone mineral density will also decline at that point onward. So men are not excused from decreasing bone mineral density and osteoporosis. The daily calcium recommended intake is about 1,000 milligrams for age 50 and above. And if you want bone protection medication, if you're having adjuncts for bone protection, you would want up to 1,200, sometimes 1,500. More so for the women who are postmenopausal. Vitamin D, usually you need 800 IU as per WHO. And I'd like to emphasize here sun exposure is a way for you to get your skin to develop vitamin D. You see, when the sun hits your skin, it will transform your cholesterol into vitamin D in the long run. And unfortunately, if you want to maximize or at your ultraviolet B rays radiation, ideally you should be exposed at noontime. If it's in the morning, not so much. In the evening, very little. So at noontime, about 10 to 15 minutes a day is good for you for your vitamin D if you are unable to get supplementation. Of course, you can get it through the diet also or pills, but natural is still the way to go. So perioperatively, you have that as indicated. Lifestyle modification, very important. Smoking and alcohol cessation. Smoking, even vaping, is still proven or has been proven to decrease bone health. It can delay bone healing. So if you sustain a fracture and you've been smoking, it's gonna take you a lot more to heal compared to the normal individual who doesn't smoke. So again, important is to have an active lifestyle, avoid immobility and weight-bearing exercises, as I mentioned, and as you can see on the right, as displayed by Marshfield Clinic. All right, uh, here we go. Here are some of the anti-resorptives. Here in our hospital, our pharmacy has alendronate readily available. It's one of the cheaper ones out there, well studied. Pretty much it has good long-term bone protection, but it's not as good as the injectables. So it's given once, well, for our preparation, it's given once a week, 70 milligrams. And like I mentioned earlier, the most common adverse effect is gastric irritation. So you have to have a full stomach, you have to remain upright, you have to drink a whole glass of water to maintain it. And like I mentioned earlier, you should really maintain this medication for a long period of time. Discontinuation will warrant you to seek consult. You may have to shift to another drug. Otherwise, the effort of you to try to protect your BMD might suddenly slip or fall if you suddenly discontinue it. More so in the IV medication preparations. If you take an IV medications, usually they can be weekly, monthly, biannual, or yearly. If you suddenly discontinue it within a period of 2 to 3 years, your bone mineral density might significantly drop. So that's why we have to have continuity of care with these patients. So we recommend you to at least have an annual checkup if it's regarding to your osteoporosis medications. Also to plug in, the Department of Orthopedics usually has bone screening yearly. I think we had foot screening for bunion this year, so maybe we'll plug in back the bone density screening next year. Here are some other drugs. They're not anti-resorptives or more anabolic or basically bone building. The medications I flashed earlier are to prevent the bone from getting destroyed earlier. The thing is, bones are constantly restructuring. Your bones do not are not the same as when you were a child. It's not the same as when you were a teenager. It's not the same as when you were adult when you become older. It's constantly replenishing itself, destruction and building. So the medications earlier are more for delaying the destruction so that at least you have some strength before the turnover to the new bone sets in. While these set of medications are anabolic drugs which build on bone. So although they don't usually mix them up at the same time, so you have two major pathways or choices when you try to protect your bones. These medications, fortunately, are already available here in the Philippines. Teriparatide was one of the more earlier ones that was introduced here in the Philippines, and now we have romosozumab, which started last year. Again, you have to check with your doctor which is more appropriate for you, because if you're a postmenopausal woman who needs some medication, then hormone replacement therapy might be for you. And like I mentioned, you have to reassess your fracture risk or basically your bone density after 3 to 5 years, because if it's still high, you should still continue. If low to moderate, consider a holiday and then reassess after 2 to 4 years. But beware, if you suddenly stop your medication, it might lead to a sudden drop. So you have to either shift or again, talk with your doctor. There is an effect on fracture healing, although there hasn't been any significant problems in terms of clinical follow-up. So these anti-resorptives increase callus, or basically the mid stage of bone healing when you have a fracture. Okay, let's go to the second major factor. We're at 11:10. I have about 50 minutes. Okay, I think we're almost halfway through. So frailty and sarcopenia, again, I want to emphasize, if you're going to take home something besides the BMD from this session, is the concept of frailty and sarcopenia, which is the physiologic aspect or factor in fragility fractures. It's an age-dependent decline in muscle mass and low muscle strength. So if you're not mobile, if you don't eat well, if you have bad nutrition, you're gonna get frail, and it's gonna make you prone to falls or injuries and won't protect you when you fall. So For example, if you are undernutrition, or actually sometimes overnutrition without sufficient muscle mass, once you fall, not everyone at the age of 70, for example, we have 3 to 5 patients at age 70 with differing BMD. One patient with a negative 2.5, if they have adequate nutrition, if they fall, they might not sustain a fracture. But if you have another person with a T score of a negative 1.5, which is just osteopenia, but undernutrition, really low muscle mass, very frail, they might be the one who sustains a fragility fracture. The thing is, your muscles and your other soft tissues will absorb the energy from your fall, preventing you from sustaining a fragility fracture. So that's why I'm really emphasizing, and the rest of the FFN Philippines is really advocating um, understanding fragility fractures in the fragility and the frailty factors of this pathology. There is no significant association with gender. There is decreased capacity to respond to stress. Like I mentioned earlier, if you fall, your muscle might not be strong enough to absorb the energy from the fall, causing you for the bones to sustain most of the energy, causing the fragility fracture. Fall risk, as I will keep emphasizing in this lecture, it happens with increasing age. If you had a previous fall, it has been researched that there is an increased risk for a fall more so within 1 year of your first fall. Fear of fall, gait, your muscle mass, balance problems, cognitive impairment. That also entails medications, or what I'll mention later, the FRIDS, or the fall risk increasing drugs. So be careful if you are. It's important to have vigilance with patients with multiple comorbidities. So again, it is a multidisciplinary team approach when dealing with fragility fractures. Your skeletal muscle accounts for 1/3 of your total body mass and functions for your movement, temperature regulation, metabolism, and the rest. So I won't go into the details of the diagnosis, but there are simple tools that can be used in the hospital. We haven't adapted it yet. That can easily suggest with just a few questions, you will know that, or you will understand that your patient has frailty already. I checked our hospital charts, and fortunately, part of the nursing services, it indicates a simple way of checking if the patient has adequate nutrition. So at least we're on the right track, but we might benefit for adapting one of those sarcopenia tools to be able to more easily and be have less of what you call inter-observer discrepancy when trying to assess for nutrition. Okay, frailty again is an age-related decline in physiological systems, like I mentioned earlier. I'll skip through that. Yeah, prevalence increases with 20 to 50% by the age of 85. Yeah, I won't go into the details. And I'd like to plug in, we're one of the hospitals in the Philippines and DOH accredited, uh, pending official accreditation for the geriatric service. So we're working hand in hand with the geriatric service. Basically, if you're not aware, it is the subspecialty in internal medicine that specializes in geriatric patients, meaning those age 60 and above, or those um, that can be considered of geriatric age or profile. So we have the ortho geriatric service, and we're working well with them, and we have ongoing projects that are trying to promote us as an orthogeriatric center. The more easy scoring system is the Prisma score. However, here we go. Prisma score, it's just a seven question survey, and it can easily give you scaling if you have a frailty or sarcopenia. If your respondent answers yes to at least three, they're already at increased risk of frailty. Okay, currently we are at 11:15. We're pretty much halfway there. I know you guys are a little busy. It's a Saturday, but I want to try to be active. Like I mentioned earlier, you need to have some form of exercise or strengthening. So we're actually going to go to a short Tai Chi session. According to the World Health Organization and multiple studies, Tai Chi is one of the proven exercises that can develop or be helpful in the setting of fragility fractures. So not yoga, not line dancing, not I keep forgetting the other one that's quite famous. Anyway, Tai Chi is currently proven to be very beneficial for the bones, for fragility and frailty. Okay, if you don't want to turn on your screen, it's okay. But basically, this is a break. Grab a glass of water, drink something, have a snack. But if you would, I will do a short Tai Chi session right now, maybe 5 minutes or so, and maybe you can teach your seniors or your parents or grandparents about this. Okay, all right. I know I'm gonna look funny in this, but I really want to advocate this. I learned this from one of my mentors from Singapore. He's from Malaysia, and they really practice Tai Chi. If you're having a hard time standing up or you have a problem with balance, just you can do these exercises um, while seated down. Okay, let's set the mood with some relaxing music. All right. Hope everyone can see me. There we go. Okay, a little orientation. Um, Tai Chi is Chinese martial art that was developed for centuries past, and it's been used to improve balance, stability, flexibility, endurance. So the important thing is you have to go slow. Most of the exercises that you're quite accustomed to go too fast. And it doesn't really build your muscle the way that we want to because we want endurance. The slower that you go, the more you focus on your breathing, the more deliberate your movements. That's why we have certain actions and certain movements will promote strengthening your muscle mass. It's also a way for you to be able to meditate, to get away, stop from thinking about stressors because it's also a factor that can inhibit you from having a healthy body. And we want you to improve also your cognition, your balance. So let's start first with a bit of a warm up. Okay. So again, take it slow, breathe in slowly, and just focus. Forget about everything, forget about work. Tomorrow is Sunday, Monday is when work starts. So you have a bit of time before you actually get back to stressful work. Okay. Let's start first with the warm up. I want you to put your legs apart, wider than your hips, and then bend your knees a bit so that you have stability. The important thing so that you don't fall or your loved ones, your elderly patients don't fall, is they have to have a stable core, which is here. Most call it the chi or the center of your body and your lumbar. So again, legs apart, wider than your hips. Flex your knees a bit, about 10 degrees, and then put your hands to the side. Now put them to your hips. I want you to shift your weight to one side, about 70%. And do it for the other side. Okay, you get a free exercise session for this lecture. And repeat to the other side. Include your breathing. Breathe in and breathe out slowly. Inhale and exhale. Put again 70% into one side where you're leaning on. Do it slowly, deliberately, and relax. One more. Last one. Okay. All right. Now I want you to focus on your center, your cheek, your torso. Okay. Take note, you should not twist your hip. You should twist your trunk, which will develop your core, your abdominal muscles. Twist to the right using your trunk and not your hips. And move to the other side. And move. slowly, and try to tuck in your tummy so that you can strengthen your core. It will also help with back pain. And left. One last set. And last. All right. Now that we've warmed up a bit, let's go into a quick rundown of some Tai Chi moves. This is called energy to the sky, still maintaining your position, legs apart. Bend your knees a bit. Okay. Put your arms to the side. I want you to raise slowly to your chest. And then push forward. Now you're becoming a karate kid. And then push that energy into the sky. And lower it down. The slower and more purposeful, the better. Again, energy to the chest. Inhale and breathe. Exhale slowly. Forward. And raise it up. And down. To the chest. Forward. And up. Last set. Down first. Energy to the chest. Forward push. And energy to the sky. It will promote with digestion, respiration, your core, and your back. Okay? All right. Next is drawing the bow. You put to the side. Just copy me first. It's a little complicated. So you forming here, you twist your body trunk to get ready. You form the set to release a bow, and then use your legs like an archer. Squat and return. Okay. Turn to the side. Draw. And go down. And repeat. Turn. Draw. And down. Turn. Draw. And down. All right. Next is called penetrating heaven and earth. With your body back in the same position. Pull the energy from the earth to your chest. One hand goes up into heaven and the other goes to the earth. Return the energy into your heart and do the opposite. Maintain your breathing. Keep it slow, purposeful movements. Again, the energy to the chest. Disperse the energy into the heaven and the earth. Center. Split. Relax. One more. Split heaven and earth. Return. And opposite. One last set. Energy. Split heaven and earth. Center. And opposite. Okay. Last one. Simple exercises for the hands. This should have been the first one. I want you to put your energy forward with your hands to raise flexibility and just turn and opposite. And return to the center. Repeat 3 more times. Turn and center. One last. I'm pretty sure the people who just got in the room are puzzled with what we're doing. And there we go. Okay. Thank you for those who actually joined me in this short Tai Chi session. So I hope you learned something. You can teach that to your relatives and loved ones so that you can promote them. Pilates. Pilates, unfortunately, not yet scientifically proven to really improve. Um, Based on my knowledge, it would help you with flexibility, some strength, but for fragility fractures, our concern is the core, lumbar. So, Tai Chi so far has been proven to be effective. Thank you for that question. Okay. All right. Time check. We are at 11:26. I'll rush through. We're pretty much more than 50%. All right. Let's get to it. Okay. Fragility fractures. Fracture risk can be stratified using the FRAX tool. It's readily available online and they have a setting for each country. So here it can calculate the 10-year probability of a major fracture. Well, that's pretty good. It's quite used often. Unfortunately, my OSTA, my other uh, assessment tool wasn't transferred when I transferred this file to this laptop. But it's an easy diagram. I believe the rehab medicine uses it often. It's a diagram that just shows you the scale with an X and Y axis for the age and the BMI of the patient, and pretty much you have an estimate of what your fracture risk is. Okay, so epidemiology and economic weight. There is a steady increase in the percentage of the population older than 6 years old and above. And I'd like to go back to that statement that some countries consider 55 and 50 years old as old already, unfortunately. If you have three or more previous fractures, there is increased risk by 10 times. That's alarming. Fragility fractures generally account for majority of inpatient costs. In developing countries, particularly Asia, incidence has been increasing. That's why we have a movement to raise awareness and improve our systems. The lifetime risk of fragility fractures is at 40%, which is the same as coronary artery disease. I'll go into some other data later, but again, this is something that we as a country have to be well aware of. Okay, like I mentioned earlier, hip fractures are the most studied or most often encountered. It is the most predominant osteoporotic fracture at the age of 75, more so in women. It causes significant disability, morbidity, and mortality. The next is the wrist, about 18%, usually at age 65. You have vertebral fractures, most common single osteoporotic fracture worldwide. About 30 to 50% of the people more than 50 years old, you may not have felt or thought that you have a vertebral fracture. And some patients come to the clinic actually saying that medyo kuba po ako or they have back pain. It might not be arthritis, but it might have been a subclinical fragility fracture of the vertebra. So it might be a compression fracture. And then less of 10% require hospitalization. Another one is the proximal humerus or the upper arm. So yeah, if you don't sustain a rotator cuff tear of your shoulder, you probably have a fragility fracture of your shoulder. Okay, let's go into hip fractures. I forgot to mention I am part of the arthroplasty service or the lower extremity reconstruction team. So basically, we deal mostly with the hip and knee. We do joint replacement. And for these patients who sustain hip fractures, more often than not, it won't heal if you use other methods. Although in certain cases it can, but our goal, as I will emphasize later on, is we want our elderly patients up and running, well, up and walking the day after surgery. It's one of our key performance indices. So by doing a hip replacement, they can immediately walk without any concerns. So hip fractures causes an array of problems. It causes further severity of chronic diseases. For example, diabetes, it will get worse, etc. You have the complications of anemia, pneumonia, delirium, UTI, and thromboembolic events. Because once you have a hip fracture, you can't really sit up comfortably unless it's been there for a while with you. But still, you won't be able to stand, and it will present you with multiple problems. There is an alarming rate of mortality in hip fracture patients, whether or not they get operated on. So even if you do get surgery within um, a few days or a week, which is done in first world countries, there is still that risk of having um, of sustaining mortality. The 30-day mortality rate for surgically treated hip fracture patients was at 4.5% in one study and 6.9 to 8.2%. That's quite high. Having comorbidities increased the 30-day mortality rate by 2.5. So patients undergoing dialysis have a 2.5 higher rate of mortality rate compared to normal individuals. Postoperative complications. 20% having hip surgery have major complications. 50% require pharmacologic intervention. 40% will have dementia. And the 30-day mortality rate, like I mentioned, is at 6.9 to 8.2%. Usually respiratory, cardiac, infection. These are the things that we try to immediately treat or prevent after surgery. So once our job as orthopedic surgeons are done, we are able to do surgery on the patient. We have to mobilize it. Whether you're a nurse, whether you're a surgeon, whether you're in IM, rehab, family medicine, any other support service, or the companion, or just a layperson, you have to um, you have to really push the patient to be able to at least sit up and then eventually stand up and walking in, because it will significantly decrease the risk of comorbidities or the risk of mortality. The usual causes of mortality, like I mentioned earlier, and then hip fracture. 1 year after sustaining a hip fracture, these are data from after doing surgery, 40% were still unable to walk independently. So you can imagine, if you yourself are happy right now walking without any aid, think of those patients who need a walking cane, who need a walker. 40% of them can't do it on their own. That's a significant blow to their daily life or activities of daily living. 60% will still have difficulty with one essential activity of daily living, like even putting on their clothes, feeding, toiletry. So 80% are restricted in an instrumental ADL like driving, shopping, and around 50% only regain pre-fracture level of independence. So once you sustain a fragility fracture, you're not really gonna go back to your pre-injury status or strength. Social support and socioeconomic status has a positive effect on functional recovery. So we really have to have a good support system for these patients. Fortunately, I've been seeing from LGUs and other um, medical projects that we're trying to keep up with first world countries. There is a risk for poor outcomes for the male gender, those with supported accommodation and pre-injury mobility with a lower pre-injury mobility, those with depression and dementia. Healthcare costs. 80% of all related healthcare costs. 10% are hospitalized for a second injury the year after. So costs incurred, this was in the States, are basically similar to acute coronary syndrome or heart attack and similar to stroke. So again, this is a very, I wouldn't say it's a silent killer, but it's something that um, we have to be aware of. So we're trying to push for policy changes to make hip fractures, or at least awareness, or fragility fractures more aware for the general populace. Mhm. Okay. All right. Let's go into a quick Q&A. I might just answer it myself for the sake of time. Complication of hip fractures other than the complication of chronic disease and mortality. You have pneumonia, you have delirium, you have UTI, thromboembolic events, or basically um, you have deep vein thrombosis and pulmonary embolism. And basically the answer is all of the above, besides other possible complications. I'd like to plug in quickly the concept of orthogeriatrics. So it's specifically tailored to patients, geriatric population who sustain orthopedic pathology, such as here, hip fracture. Like I mentioned earlier, there is an increase in the age life expectancy of people. So there are a lot more older people, and we need them to be independent for a longer period of time. Otherwise, there will be an increase in healthcare costs, not just for the family, but in general for the whole country. Fragility, fracture, postoperative return to function, quality of life has to be addressed, and we have to address frailty. Again, this is a multidisciplinary approach when talking about fragility fractures, and here enumerated are the multiple departments that we want on board. There can be more. It can also be ENT, OPTHA. If you have poor visibility, that can also be a risk factor for falls. So really a multidisciplinary approach to treating these patients. Orthogeriatrics starts at the onset when the fall happens. Acute care in the with the ambulance. Unfortunately, we still have to improve on that. The logistics of bringing in patients who sustain a fragility fracture. And again, unfortunately, we have a lot of patients who just think that it's just a bone. It's just a soft tissue contusion. Um, the family just thinks that it will get better in a few days, but unfortunately, it's apparently a hip fracture. So we have to raise awareness and get these patients seen at a primary institution or a tertiary hospital. So perioperative care, we need to see them pre-op, optimize them, prepare them, and then prepare for post-op, which is early mobilization. Early authorization, we need to get them sitting at least the day after, and then eventually be able to stand, walk, and then be able to become independent. Okay. Nursing care, very important. It's for their quality of life. Continue to give empowerment, check healthcare associated problems, check if they have infection, pressure ulcers. I haven't mentioned so far in this lecture is a common thing. If you keep staying on in bed, and if you're a little in that again that age group, your skin will be very fragile, friable. So by just sitting down the whole day actually puts you at risk for pressure ulcers. So you have to look at the buttocks, you have to look at the elbows, you have to look at the heel. More often than not, there can be heel sores from the patient. So be careful of falls and drug administration errors. And then we have to also address pain. And then rehab can be started even before surgery. Even if the patient is just in bed, they can start by increasing upper body strength, and so that when they are up and running, they have a strong upper body strength for their walker. And then, of course, for those less fortunate who have worse outcome, we have palliative and end of life care. Secondary prevention. Okay, once you have sustained the fracture, there is the greatest recurrence is within 1 year of that fracture or the so-called imminent fracture. So we have to prevent another one from happening. Just because we are able to discharge the patient from the hospital, it doesn't end there. It has to have continuity of care with the OPD and not just with orthopedics. We need IM there, we need rehab, we need family medicine, we need nutrition to be able to address the basic concepts that I mentioned earlier, osteoporosis, which is fragility, and fall risk, which is usually under frailty or sarcopenia. Oh, hello. Yes? No, I think they just paused the unmuted. Okay, fall risk. It can be stratified into low, intermediate, and high. So those of 65 years and above are at higher risk. If you have cognitive impairments such as dementia, you're at higher risk, and all those mentioned above. Like I mentioned earlier, if you have multiple comorbidities, if you have multiple medications, we really have to be vigilant in terms of pharmacovigilance to see if there will be medications that will be increasing your risk of falls, or what we call FRIDs, fall risk increasing drugs. So cardiac related, that can cause orthostatic hypotension, dizziness, nausea, vomiting, blurry vision, etc. And even pain, of course, can cause problems because once the patient tries to get up, if they're not fully aware, they can slip and fall, and then you get a refracture. I won't go into the detail. We have several studies and CPGs to try to address fall risk. And yeah, maybe I'll just go into the others. Here, fall risk stratification can be done in 5 minutes. Just ask the history of the fall. Do they have a fear of falling, or they have risk factors for that? They have feeling of unsteadiness. Tug is the timed up and go test. I'll show that in a few slides later. But it's a quick exercise to see if the patient is at risk for fall. Fall prevention, I won't go into detail. Yeah. Oh, sorry. This is where our Tai Chi break was supposed to go. Anyway, um, let's see. Okay, protein. I'll be discussing a little nitty-gritty on the orthogeriatrics part. The ones that we can address, even if you're not a medical professional, you can just recommend it to the patient. Protein, energy, malnutrition. So we need to improve their diet. Having a balanced diet, you really need fruits and vegetables. You should not underestimate protein. Yes, we are afraid of cholesterol, but you still need protein in your diet. Yes, we're Filipinos, so we're wary of sugar, but you need a certain amount of sugar to keep your body energized also. And then the rest. If you're looking for a safe alternative for protein, go with tofu. The rest is more administrative, so I won't go into it. Here's a simple way to address nutrition problems. This is called the simple acronym. Screen, do an interdisciplinary assessment. Even if you're not a medical professional, you can just ask around or um, look at guides online, make the diagnosis. It can be done at home with those questionnaires that I mentioned earlier. Plan with the patient, implement interventions, the diet, how you go about it, and their feeding manners. Evaluate ongoing care requirements, meaning you should have feedback. Once you start a treatment, there should be a feedback or a follow-up. So that's important. Just mentioning here in Canada, they've been doing this from 2016 and they have a good feedback by when they raised awareness. What they do is they note down how much the person feeds on, and they pretty much have a algorithm or a table of how much the kilocalorie requirement they have for the day, and then they see it there. Once the patient sees that on chart, they're not eating enough or they're lacking in terms of what they eat per serving, they become more aware. They get energized to actually do the right thing or eat better. Nutritional assessment, this is a breakdown, ABCDEF, anthropometry, biochemical measurement. We can't do all of this outwardly at home, but we can try to address some of them at home. So there are screening tools. Nutrition, we need about 30 kilocalories per kilogram per body weight in older patients, which is higher than in the normal adult. Hydration is also important. We need to have a balance. You need to hydrate also. Soft drinks, please try to avoid. Here's a little tidbit. I'm just plugging it in. Um, Coke Zero technically is not zero. There's still some. Diet Coke, there is less sugar, but it might actually be better than Coke Zero. Please don't quote me on that. There are still ongoing studies, but suffice to say, those zero fluids or drinks are not completely zero. They have indirect mechanisms. Nutrition, energy expenditure, metabolic stress, reduced food intake due to lack of appetite, nausea, psychological factors, stress, etc. What you can do, the simplest, I'm sure you guys pretty much know this already, multiple small meals and snacks. Elderly patients are very picky. If they don't like what they see or smell what they like, they don't eat. So one technique is small frequent feedings. You can get something that they like and then you just feed them at certain points in the day. The usual recommendation is 4 to 5. feedings. You might not need an actual dedicated breakfast, lunch, dinner. You'll just do those feedings. And then I won't go into those details. Mobilization. This is very important. Like I mentioned earlier, it will decrease the risk of complications and refracture within the next year. It's also to prevent thrombosis, pneumonia, respiratory failure, delirium. There are, again, scoring. I won't go into the details, but they're important to note so that we can get these patients independent again. Because even if you do surgery, if you don't empower them to be able to be independent themselves, you're pretty much going to need a companion at home, whether a relative or you're going to hire, which is more costly. In the end, the household or the community and the government per se will be dishing out more costs. That's why the cost of fragility fractures is close to coronary artery syndrome and ischemic stroke. Older patients treated with hip fractures are unable to follow weight restrictions. I'm sure everyone knows that a lot of our parents and grandparents, once they reach that age, they don't really listen to you, even if you're reasoning out properly. So even in terms of ambulation instructions, if you tell them that you should not put too much weight on it, they won't follow you. So as orthopedic surgeons and in rehab doctors, we work in tandem with them. We do our surgery so that we're confident that they can stand up immediately the day after. So that's why we advocate arthroplasty for selected cases, of course, so that we have no problems. We're confident on making them walk immediately after. Although I'd also like to mention that arthroplasty does not have its own possible complications, but again, it's a very cost-efficient way to be able to get these patients up and running again, up and walking again. Initial post-operatively pain and fatigue. Okay, pain will be handled by our anesthesiologist friends. Fatigue, nutrition, and prehab. Prehab is preoperative rehabilitation. So, like I mentioned earlier, even if you're sitting down in bed or lying down, if you start doing exercises, your body will feel it. You will feel stronger. You will have the necessary energy to be able to get up and mobilize the day after surgery. And then hypertension and fluid management, because if you have a risk of hypotension, that's a risk for fall, and also it precludes other complications such as infection. Rehabilitation, I'm sure they have their own assessment tools they can share with us in the orthogeriatrics side as well. Our goals again is to treat fragility and frailty, which can be addressed with rehabilitation and physical therapy. So again, it's important to do a multidisciplinary approach. Psychosocial, depression, delirium, cognitive impairment, Alzheimer's, Parkinson's disease. These are things that we have to take into account. Post-stroke, you have to take into account when treating these patients. So also the caregiver psychological status. There was one research that uh, put emphasis on the psychological health of the caregiver. It's not easy. I've been taking care of some elderly patients from my side of the family. It's very difficult. Again, they are hard to treat. They are not as active. They are very hard-headed, and that will put stress on the caregiver. And if you don't have a good balance for the caregiver, the quality of their caregiving is not going to be good, which will decrease the quality of life of your geriatric patient. Okay, quality of life. I just like to mention quality of life is has a numerical value. It's not just 0 to 100. In Europe, quality of life can be negative. There are patients, more so those who are not able to undergo surgery for hip fractures, who put their quality of life at a negative, meaning they would rather, unfortunately, say that they want to pass away already rather than continue on living. So that is an important and realistic matter that we have to take into account. It's not just because we've done surgery, we've done what was necessary. We need to do more for the patient. We need to empower them. We need to mobilize them. Otherwise, they're going to be a negative quality of life, and it will just be a spiral or cycle of not being able to mobilize and go into complications. And then, sorry to say, mortality. EuroQual is a European quality of life survey. We've been using it in our hip care project, which is a project we're doing with UK right now to promote and treat fragility hip fracture patients. I think we're almost ending. I won't go into the details. Mobility, again, emphasized. Protocol or targets. Our hospital, as our department, we have our own protocol. Although we are planning to combine and talk it out with the rest of the orthogeriatrics team to be able to address all of these targets. And like I mentioned earlier, even if you are not medical, you don't have a medical background, you can address the two highlighted in red. Malnutrition by just recommending them proper diet. I forgot, in terms of protein, if you need a quick remedy, egg whites. Egg whites in eggs. Just give them 2 egg whites per day. That might address a lot of your protein requirement. Besides, of course, their usual eating habits or their routine. And then early mobilization. Here's a sample case. We have 3 minutes. I think we'll reach in time. This is a 62-year-old female, retired previous community ambulator, meaning they can walk without problems outside by themselves independently. Has diabetes. Take note of that. Had a ground level fall. Basically, just slipped, fell, sustained a hip fracture. If you can see, there's sorry, pardon me. There's a hip fracture on the left. Here's going. Here's a zoom. There's no more continuity between the femoral head and the femur. This is the side, not as clearly seen, side view. Patient underwent total hip arthroplasty. We replaced it. It's back to length. It's stable. Good. We use cement because the bone was porotic already to add stability. Patient was able to sit immediately day after surgery with assistance. Here, independently with walker. A little imbalance, but at least day one, patient was able to stand up already. Was able to walk a few days later. However, sustained had an episode of diabetic ketoacidosis, but was pretty much handled with no problems and was ambulatory with no problems on follow-up. Sorry, didn't get to plug in the video. It wasn't working. And there you go. Patient ambulatory, no problems with gait. Last few minutes, I'd like to mention again, I'm part of the Fragility Fracture Network Philippines. It's a global congress trying to promote awareness of fragility fractures, osteoporosis, hip fractures, etc. Fracture liaison service is basically a concept to be used in any hospital. If you have a fracture, not just fragility fracture, ideally, given the resources, you will adjust to what you can do for the patient and then try to address it multidisciplinary team, do it quickly and with the capacity of the hospital and adjust to it. By having a fracture liaison service, which is a multidisciplinary team, it decreased mortality by 50% and secondary fractures by 20%. So that's very important. These are all under projects of the International Osteoporosis Foundation and the Capture the Fracture, which we are also part of, proudly to say. We have a bronze star in the Philippines. So far, I think POC is the only one with a silver star in the Philippines. Summary, we're pretty much closing. Summary, we were able to discuss fragility fractures. Main points are osteoporosis or fragility itself and frailty, sarcopenia. Please take note of the concept for sarcopenia because it's real and you have to understand that. We understood the pathophysiology and the long-term effects. We had a multidisciplinary approach. I emphasize the need for a treatment adherence and prevention because there can still be complications even after a year. And again, it's not over yet. After 1 year, after 3 years, you have to have regular follow-up. And that ends it. Thank you. I was supposed to have a link to a post test, which is not actually a requirement. You might need to have a post test from Petro, but I think you already have that link. So we're pretty much done. We're at We have 5 minutes. Do you have any questions, or do you want me to post the post test? Actually, the post test is pretty easy. So that's it's a review. Okay, raise your hand for any questions. Yeah. Or do you want to do Tai Chi again? Okay, I'll wait for a minute. Oh, I'd like to plug in also. This is a free ebook in online. This is Orthogeriatrics. It's the second edition. It was developed by a multi-specialty team from it's multiple from US, UK, Europe, and Asia also. So it highlights everything from top to bottom, from establishing orthogeriatrics, the fractionation service. It has stuff in for orthopedics. It has stuff for anesthesiologists, internal medicine, rehab, dietary. They have it all there. Even in for nurses also. So if you want to improve on your department, just download this online and read up on it. You can readily or improve your systems by just reading up on it. Lots of hospitals have done several researches and trials to be able to get their orthogeriatrics team up and running and their fracture liaison service to be able to cater to these patients and significantly decrease morbidity and mortality. Okay, I don't see any questions from the chat box. So again, thank you for attending. Pardon the problems, technical difficulties, and we'll hopefully see you again for the next equip lecture next month. Thank you. I'll stay here for a bit and wait for any questions, but you can sign out now. Thank you. Certificate. Unfortunately, we'll have to ask Petro. I was informed late that we didn't get CPD units for it. Yeah, I'll ask Petro if we can get a certificate for it. I don't know if we'll be able to. Do we have a representative from Petro here? Maybe you can answer if we'll be getting a certificate. If not, I'll ask. I just don't know how we can send out the certificates to all of you. Although I think they recorded your names in the email. All right. I don't think we have any more questions. If ever you do get to think of one, just feel free to get in touch with me or any ortho and visit us at our OPD. Thank you. That concludes our lecture series for this May. See you in June.